Welcome to the Dr. Shawn Tierney Podcast. My name is Shawn Tierney, and I am a neuromusculoskeletal sonologist. I treat athletes and high performers. My goal with this podcast is to help you make better decisions regarding your health, athleticism, and all aspects of life. Here, I'm both a student and a teacher. Thank you for tuning in. Hey, this is Dr. Shawn Tierney with the Dr. Shawn Tierney Podcast. My expertise is musculoskeletal ultrasound and ultrasound-guided procedures. I teach that internationally. We're adding perspectives to understanding of problems with healthcare with this new technology, and it's changing our understanding for doctors as well as for patients and our ability to solve problems that we couldn't solve before. And more precisely today, our focus is two commonly done procedures with ultrasound-guided injections called the Stellate Ganglion Block and the C1 Plexus Hydrodissection. We've identified these as the procedures that are the big guns, the most dramatic and effective lasting change we can make to the autonomic nervous system. And today, autonomic nervous system dysfunction or dysfunction is a common problem, especially post-COVID. A lot of stress going around. So post PTSD, post concussion, post overtraining, overworking, overstressing. This is a big issue, and people are suffering. And this is one of the big solutions. So here we're going to go through this presentation and hopefully help you understand what's available to you, and as a physician, what's available for you as a provider. So let's go to my biggest thanks is to Dr. Shawn Mulvaney, Colonel Shawn Mulvaney, retired Navy and Army officer who did well over 30 studies on stellate ganglion block. Probably the most important person in treating PTSD and in our military history. 60 Minutes did an article on it, did a show on him. It's been on CBS this morning, testified before Congress, published multiple studies, including a JAMA multi-clinic level 1 study for PTSD. So in my recent world, Shawn calls himself Shawn Channel of Bones Mulvaney, because we crossed a channel of bones together last year, the channel between Molokai and Oahu stand-up paddle race. And that was his new name for us. He signed his name that way. So just want to honor that. It was a great experience to share with a good friend. Let's talk about this stellate ganglion block. So the stellate ganglion block, well scientifically proven. Of the stellate ganglion block versus the C1, this is the one that has the most study and is the most understood. We're not saying it's more or less important, but we have more data. So with the stellate ganglion block, we're able to reset the autonomic system. It's kind of like rebooting a computer. Sometimes a computer gets just too much electrical activity and it can't function normally. In the case of our brain, electrical activity is partially related to neurotransmitters are released between neurons. And at a certain threshold of stimulation, it turns out that our nervous system gets turned on, and part of it can't be turned off because that excessive stimulation makes it run fast. And it seems that the neurotransmitters at that pace can't be taken away. So you have too many neurotransmitters sitting in that part of the nervous system. And this is, just a hypothesis of what's happening. With good indications. The biggest indication is that if we were going to do a stellate ganglion block or an autonomic block, and we did it with an anesthetic that lasted for 2 hours, we don't get a lasting effect. But if we did it with ropivacaine, which is commonly used, that lasts for 4 to 6 hours, now we have a change. So the difference is that longer downtime allows a longer rest or slowing down of the nervous system, slowing down to normal, not slower than normal, allows those extra neurotransmitters to be reset. It's kind of like if you turn off your computer and reboot it. Sometimes it's not enough. Sometimes you have to turn it off for like 5 minutes and then turn it back on. And then you get a nice reboot and the computer functions again. In the cases of our nervous system, if it's too busy, it's overstressed and it's harder to do things. And we just don't function as well. And we have these common symptoms that happen. So the stellate ganglion block blocks the sympathetic chain around between C7 and C5. And sometimes it's C4 now with the later technique as well. So this blocking of that autonomic system, that sympathetic side of your nervous system, allows the relaxation to occur and the parasympathetic side of the nervous system to express itself. So we have these typical findings of anxiety, wanting to go and check on everything, not being at peace, emotions being out of control, maybe having some digestive dysfunction, reflex dysfunction, feeling like it's harder to function in life in general, maybe some anxiety, agoraphobia. But this is just these common symptoms that happen, whether you had a battlefield bad experience, a surgical bad experience, an assault, a time where you were just overtraining and not functioning very well. The interesting thing about this stellate block is it does help with anxiety and stress, but it also helps with functioning. So you think more clearly, you can resolve problems in more time because there's less windows in your mind to go through. Like if you have a computer that has too many windows open, it runs slower. Or an iPhone has too many windows, it'll run slower. And you know what? The battery goes down if it's your phone, right? The battery's going to go down slower if you have too many programs going. If you take all those extra programs off, battery lasts longer. And whatever you ask your phone to do, it just does more quickly, which is nice. So you're using less energy and you're getting things done with less effort more quickly, which is effective. So that's something not to be taken lightly. So what we're saying in your nervous system is, okay, you think more clearly, you make better decisions, your reflexes are faster, your vertical jump is higher, you're stronger. It's performance enhancing and it's drug free. It's important performance enhancing because they take the background noise out of the nervous system. There's a faster and more efficient connection between your nervous system and your body. And if you're trying to think, and if you're trying to accomplish things with your nervous system, it just happens faster with less effort. We get more done with less time. And that more done with less time is really the fact that when we're in the moment, all the time, we get more done. Because there's a lot of time that we spend processing. So if you think of an hour, if you're working doing physical or mental work and 50 minutes out of the hour you're processing and you're really truly in the moment working for 10 minutes, well, you get 10 minutes done. And it turns out an hour at that point feels 10 minutes long, except for you actually did 60 minutes of work because your nervous system was working. So you're getting tired and time goes by faster. So if you take all that background noise away and you're in the moment for 60 minutes out of an hour, you can imagine you're going to get 6 times more done. And it tends to feel like the hour is 6 times longer. But at the same time, you feel like you're more relaxed and you're taking it easy and you're not working as hard. And that's true if whether it's your physical work or mental work. We talk about athletes that have been going through this process. They'll say, hey, I feel like I was just taking it easy and going slow, but when I saw a picture of myself, I was going very quickly. And I take that back to what we do with observing athletes. So if I look at one of the greatest athletes ever, probably Michael Jordan, if we slowed him down and saw him do a slam dunk, there's so many things that are happening. He's moving, he's twisting. It's like he's flying through the air in slow motion. If you take another athlete that's doing the exact same motion and you slow it down, there's not as much happening. Because that Michael Jordan was very present to the moment. There was not any background noise. He was 100% there. And even though it happened really quickly, his perception of time was different because he was doing more. Whereas the athlete that did this same procedure but didn't actually move as much, you could tell his perception of time, his ability to be in the moment wasn't at the same level. So what ends up happening is you're stuck in that position as an athlete. What some athletes end up doing is taking stimulants, sometimes some very intense stimulants that would surprise us. So to overcome that difficult ability to get to the moment because they have to get through so much neurological activity to get present that they need something to push them, which is going to use more energy and make it harder, even though you do maybe accomplish things. It would be much easier if you were just in the moment and you weren't using as much energy. And I think that's what a lot of these elite athletes are able to do. And we have some, podcasts on this, particularly with Danny Ching, that kind of describes how that feels for a world champion athlete going through that process of having a stellate block versus not having a stellate block, being overtrained versus not overtrained. So that's a good reference to go through. So that's some subjective things that there's not much there for. But, my friend, Dr. Shawn Mulvaney, fortunately did a study for his Special Forces operators, published in Special Forces Medicine, showing that, your reflexes are improved after a stellate block, your cognitive function is improved, your short-term memory is improved, your solving problem ability is improved, and then we did further studies with athletes to show, hey, you're faster and you're stronger, and they did also notice with Special Forces athletes their shooting accuracy increased. It got to the point where some of these athletes would get a block before they went out, even though they weren't stressed out, they didn't have PTSD, because they knew they would perform better and they were a safer, better Special Forces operator after recently having a stellate block. And we're starting to see that happen for athletes. They'll get a stellate ganglion block immediately, 2 weeks before or 1 week before, depends on what they feel works best for them, their major event where they have to do the best in their career. So that stellate ganglion block, there's a lot to it. And that's one of the functions here. Now you see on this slide here, you can see we have actually the stellate ganglion block on the slide with just sitting right in front of the C7 vertebrae. We usually block it at C6 just for the safety of the anatomy in the area. We don't want to block right next to the vertebral vein or artery, which is where it sits at C7. So let's go back and look at an actual procedure, a stellate ganglion block happening. So we see this stellate ganglion block. I'm just going to turn this on and I can see, the carotid artery pulsing. We have some Doppler there. And then, so we're going to make sure we know where the arteries and veins are. Because one thing we don't want to do is put ropivacaine into an artery or a vein. That very large artery vein could be, obviously a very big problem. Here we're guiding the needle. It's in the longus capitis into the longus coli. The sympathetic chain sits in the plane between the longus capitis on the coli and the coli. And you see the sympathetic chain kind of on the top of the longus, the fascia of the longus coli as it expands. And now it's sitting against the internal jugular vein, which is compressed by the probe. To the left of the carotid artery, and right next to the carotid artery, you see the vagus nerve. And you can see that sympathetic chain kind of move laterally as that fluid's pushing it and surrounding that sympathetic chain. Now we take the block out, and that's the whole procedure. So that's a stellate ganglion block. It's surprisingly not very uncomfortable, quite effective. That map of all of that anatomy there that we're seeing in a two-dimensional view is fairly high resolution. But we need to be able to go through that very clearly, know all the arteries that are in the area, all the veins that are in the area, be aware of where the vertebral arteries, the thyroid arteries, the current laryngeal arteries are. We need to be aware of where the cervical plexus is. And we need to know where the borders of the internal jugular vein and the radicular arteries are. So we go through that process of mapping it out, and we are able to do a very safe procedure consistently. We've done thousands of these, and it's a very, very safe thing to do under skilled hands. And then the question is, how do we get more skilled hands out there? How do we get more people trained? Well, that's what we do. And hopefully we spark some interest in some healthcare providers to learn to be a bigger part of providing this service to their patients. I was fortunate to be lucky enough to teach with Dr. Shawn Mulvaney for well over 12 years, and we were able to teach the first VA to actually start doing stellate blocks. So they're actually being performed for the VA, and it's not just a elite SEAL team, special forces, East Coast activity now. So we have it on several military bases. We've taught on military bases in San Diego and Camp Pendleton and in Orange County. So we've taught at several places, and he's taught much more within the service. So we're seeing this thing gradually take off, and we've learned what it does. It slows down the autonomic system, it slows down the nervous system, so it helps the parasympathetic system be expressed. Let's go back and let's look at the next procedure, which is actually a hydrodissection. And I think for a lot of you, not all of you, and hopefully not most of you, hydrodissection is a new procedure, a new understanding, and something that needs to be defined. So hydrodissection is a new tool. It involves the use of musculoskeletal ultrasound to carefully and precisely guide a needle to inject fluid with the purpose of separating tissue planes around nerves, tendons, ligaments, and vessels. So we can accomplish this hydrodissection internally. So there's this idea of myofascial release that physical therapists, chiropractors, manual therapists, osteopaths will do, which is fantastic. But you really can't get very deep from outside of the body. So with ultrasound, we can look at a fascial plane. We can look at a nerve, an artery, whatever structure we're looking at. Like we can guide a needle between nerves in the fascial planes of arteries and in the perineural sheaths of nerves, and inject fluid to break the adhesions or connective tissue that's allowing compression or restricting the motion of nerves or vessels or other tissues. So hydrodissection is a very benign water pressure, hydraulic pressure separation of connective tissue and restoring normal function to nerves and blood vessels almost instantaneously within minutes. So it's not unusual to have somebody come in for, needs a hydrodissection, and we see their muscles that are not been working to work again. And we talk about this because the other procedure besides a stellate block, which is, block is, there is hydrodissection that happens with a block, but it's usually used with a local anesthetic, whereas a hydrodissection has very little, if any, local anesthetic, but it has a purpose of creating more space and more function, whereas a block has a purpose of either numbing or resetting an area neurologically. So another way to define hydrodissection is a precisely guided use of hydraulic pressure to establish an internal connective tissue dehesion. So hydrofascial dehesion might be a word that's used as well. There are webs that hold connective tissue together, and these are produced by your nervous system, your immune system, immune cells, to regenerate your body. When we think of immune cells, a lot of times we think of just as an infection, but immune cells, are regenerative cells. So if you rip your skin open or rip something apart, your body throws out these webs or strings, fibers that pull the tissue back together, which is amazing if you have something that's ripped apart. It can heal. It can stitch itself, even without stitches, back together. If we have that same immunological process that's happening between muscles where nerves and blood vessels need to move, and there's a lot of these adhesions and strings, now we're creating some potential pathological problems where the nerve can't move, the nerve doesn't function, the vessel can't move, the vessel doesn't function as well, and we're changing the function of an area and causing partial paralysis or even paralysis, sometimes, often causing pain and disability. Now, when we talk about dissection is something that has been around for a long time. You dissect the cadaver in anatomy class, you dissect connective tissue with surgeries. But, this requires the use of a scalpel or a blunt dissection. And what we find when we're dealing with dissecting nerves or neuroplasty is that often the relief is temporary, because it's the same thing we talked about. If you cut something, your immune system tends to stitch it back together. So it's not unusual that I see, after a surgical release of nerves, that everything feels great and functions very well for a few weeks, and then gradually it gets back to where it was. Sometimes worse, as that immune system adheses those tissues back together. So with hydrodissection, we can do something that's much less traumatic, with very minimal recovery, just using water pressure guided clearly by a needle under high resolution imaging, and we can get a very effective, often longer lasting, much safer, and more comprehensive result than a surgical hydrodissection, scalpel or blunt dissection. All those things are good, and there are techniques that even in surgery where you'll use to prevent that adhesion from happening. But hydrodissection is certainly not only an excellent tool for separating tissue, it's in effect an internal myofascial separation or a true myofascial release to allow nerves to move between muscles. And we have to remind ourselves the muscles don't have a sensation for pain. If you have pain in muscles, it's the nerve that's restricted in its motion through the muscles. So we need to break those adhesions. We need to restore that normal nerve function and motion. And nerves need to move tremendously as we move. Inches. The brachial plexus is moving 2-3 inches, as you turn your head right and left. 3 as your arm moves. These are very, not insignificant structures that are moving very significant distances between muscles, and they need that motion for you to be able to move and function freely. So that misunderstood effect of peripheral nerve and peripheral vessel adhesions, now we can address, and we have a new perspective on our ability to see and make changes in people and their symptoms and disability with minimal downtime, minimal stress. The least invasive dissection available is likely the guided ultrasound hydrodissection. It may be the most misused or underused therapeutic procedure in modern healthcare. So it's exciting that you as a physician are thinking about taking part of this or doing this or even referring for this. And it's exciting for a patient if you have a problem that hasn't been able to be resolved, and now we can resolve it. We're basically, with this technology, we have the ability to restore range of motion, strength, function, sensation, and pain relief immediately. So the relativeness of that immediately is now we can diagnose your problem. I think your problem is this nerve is impinged right here. We hydrodissect it. It's a minimally invasive procedure. It's just an injection, and instantly your hand works or it doesn't work. We were right or wrong. After a decade and a half of doing this, we tend to have learned to be right a lot more often. But either way, it's a very precise and effective way to know the truth. We're constantly proving ourselves right and wrong, and we have a clear, concise diagnosis. So this is not only a treatment, but a diagnosis of your problem. The common solution used for basic hydrodissection would be 0.1% lidocaine or 0.2% procaine with a total volume of 10 cc's using either 5% dextrose or sterile saline solution. Sometimes people use Quinton saline solution. And often people will use a small amount of dexamethasone just to prevent that inflammation and rehesion, or other more advanced regenerative solutions that both decrease inflammation and increase healing. So when we do have a chronic inflammatory condition, sometimes we tend to use those more advanced solutions that can be talked about at a different point. As more providers understand this technology, there will be a dramatic drop in the incidence of chronic pain and disability for our entire population. So we look forward to that happening, at least now, because you have this knowledge. You can be one of those providers, or you can be one of those people that are able to improve their function and improve their life. It's an effective step. This hydrodissection, the use of hydrodissection, is an effective step towards a brighter human experience. It's accessible, it's minimally invasive, no downtime. It's not really a surgery, so we can make a dramatic internal change. Here we have a video of an actual hydrodissection occurring of the radial nerve at the spiral groove, which is commonplace for the radial nerve to be impinged in the lateral arm. The radial nerve kind of wraps around it's going to wrap around the arm, and then come to the anterior elbow, and then wrap around to go to the lateral hand and lateral forearm, posterior lateral hand and forearm. So here we got the video, and we can see a needle coming in slowly from the left of the screen, coming through that brachioradialis down to that little circle right there, which is the radial nerve. And we're injecting some fluid, pushing the nerve off of the humerus where it gets impinged. We're creating space around the nerve so the nerve can move freely around the humerus without adhesions. We're enhancing the motion of that nerve. It's basically a fascial chain separation, and we're ready to go ahead and get the top side of that nerve to the more superficial side, but that's the end of that video. So we're going to use that technology, that hydrodissection that we just went through, to address one of the most vital and vulnerable areas of our body, the C1 plexus. And the C1 plexus includes the vagus nerve, the internal carotid plexus, the superior laryngeal nerve, the spinal accessory nerve, and the hypoglossal nerve, along with the glossopharyngeal nerve and the facial nerve. So this plexus of cranial nerves primarily is in the most efficient position to get nerves from the skull to the body. I say most efficient because nerves don't have a stretch to them. So as we move our head, this is the area of our spine that has the least amount of motion right here. That's where the C1 plexus is. Now, it's between the rectus capitis anterior that attaches, between the occiput and C1, and the digastric that goes from the mastoid down to the hyoid and to the mandible. So that those two muscles, any adhesions in those areas or in that nerve plexus can cause some dysfunction. And dysfunction of what? Well, what do the nerves do? Well, hypoglossal, glossopharyngeal, and vagus, they go to the tongue. So that's your taste, that's your tongue function, your pharyngeal arch. So there could be a taste issue. After COVID, we've seen that. There also could be a blood flow issue or blood pressure issue. So what I'm saying is, hey, all of a sudden we're thinking, hey, some of these viruses that people get, some of these infections that are affecting those nerves. So any people have these regulatory problems because not only is the vagus nerve there, which is the parasympathetic chain, the parasympathetic control, but also the sympathetic chain called, in that level, is called the internal carotid plexus, and just below it is the superior sympathetic ganglion, also runs through that fascial sheath, along with the facial nerve and the spinal accessory nerve. So, but those two nerves, the internal carotid plexus, the sympathetic chain, and the vagus nerve, big important nerves for the function of our bodies, controlling blood flow to the brain, blood flow to the body, digestion, that controls your pupillary ability to constrict and focus light, your eyelids. So if that's damaged, then we can have some ptosis. It controls the blood flow to the brain, which makes it important after strokes. Also tends to be a little bit, the procedure of hydrodissecting area tends to be a little bit more in favor of sympathetic stimulation, than parasympathetic stimulation, but it re-regulates both. So sometimes people have too much sympathetic stimulation, or those sympathetic nerves are overly active in that area. And as a result, people have really high heart rate. Sometimes they have a lack of sympathetic stimulation. The vagus nerve is functioning well. They have a very low heart rate. So when we hydrodissect that area, those heart rates return to normal, and those low heart rates return to normal. So somebody may have a low heart rate and a lower blood pressure because those nerves are irritated there. And we do a C1 hydrodissection, and that heart rate of 40 is now normal. That blood pressure that was very high or very low is now in a normal functional range. So maybe when somebody stands up, they don't feel like they want to pass out. Or maybe somebody is want to avoid having a stroke or a heart attack. And the other thing that's happening there is, that these nerves are controlling, your heart rate and the electrical conductivity of your heart. So you may have this irregular electrical function in your heart that is also going to be re-regulated when we actually treat C1. So we're thinking, okay, we have a heart issue, the heart's not working, we have electrical problem. Hydrodissect C1, that problem changes. It's not going to solve every problem, but we recognize that adhesions and inflammation in that area has a dramatic effect on heart rate and blood pressure, heart function. So let's go to the facial nerve. So facial nerve also in that area has an effect on a lot, masturbatory function, the digastric, a lot of effects of the facial function. But the most relative thing that I see is it's affecting the muscle called the stapedius, which controls the tone of your eardrum, and it also controls the position of the auditory canal. So that's controlling the pressure in the middle ear. So when we do that C1 hydrodissection, we tend to correct for 3 of the causes of tinnitus or tinnitus, or ringing in the ears. So the 3 causes would be, regulation of the eardrum, not so good. Pressure in the middle ear, not so good. And the other cause would be, there's an alteration in the blood flow and function of the auditory portions of the brain, and now we can address that by regulating the blood flow, increasing the blood flow, and often the ringing in the ears will dissipate, sometimes immediately, sometimes over the next few weeks. But it's just one of those things. Not going to solve it every time, but we do see a change with that. And if somebody does have, blood pressure issues, heart rate issues, tinnitus, and focusing issues, along with the other nerve that's there, spinal accessory nerve. So you have trapezius issues and SCM issues that are tight. You start to think, well, that's a lot of those nerves are from the C1 plexus. Maybe we should address that. So the big guns for addressing this autonomic system, like I said, is that C1 Plexus Hydrodissection and Stellate Ganglion Block. There are other things that we use, and it's not to discount anything else. But if you haven't started addressing the autonomic nervous system through these 2 procedures, we have to think that maybe you're not catching all the potential ways that you can solve that problem. So let's go in and look a little bit more of how this is affecting. So one thing is, if you have an infection in this area, chronic infection of any nature, inflammatory condition of any nature, sometimes a hydrodissection is going to be enough, and sometimes it's not. And sometimes you need to go in with something that's going to have a lasting anti-inflammatory, immune-enhancing, anti-infectious effect to that area, and you get a lasting result. So typically, we'll do a hydrodissection without that super functioning injectate, and we'll get a temporary relief. It doesn't last as long. We come back and use a super functioning injectate, and then we have a lasting relief. The other thing is that we have to consider that we're not only addressing those nerves in that plexus, we're also addressing the brainstem, origin of those nerves. And we know that if somebody has a lack of blood supply that's from a stroke or an infection or just a hypercoagulability, those smaller vessels in the brainstem are more vulnerable than the larger vessels in the cerebral cortex, other parts of the brain. So strokes tend to affect those cranial nerves more. We know that. This hydrodissection tends to affect the brainstem as well, we do see increases in coordination, increases in function. They can't be explained by those nerves alone. So we have to consider that we do have an effect on the brainstem. We also have to consider that whatever we inject there is sometimes transported through the nerves into the brainstem and making a change in the brainstem. So we can't discount that. We have to look at the effect of that infections in that area. So that C1 plexus hydrodissection becomes all of a sudden a big deal. I just want to compare C1 plexus to stellate ganglion block because the two guns we're going to be hopefully clinically playing back and forth. Where do we go with these? Which one is the ideal? So, if we list C1 effects, it resets the autonomic system towards focus and function in their brain. Usually modulates up and down. A lot of times, whatever way you need to go. So it may make a relaxed person more alert, an overly alert patient more relaxed. Stellate ganglion block tends to take a busy brain and relax it. So, and that definitely, temporarily when the local anesthetic is there, we're enhancing their parasympathetic nervous system because we're turning off the sympathetic side for a period of time of probably 6 hours. C1 tends to enhance overall that sympathetic function. As a result, our sinuses get really clear when you get a C1 hydrodissection almost immediately. Sinuses get clear. Vision a lot of times improves. Our ability to focus light. Stellate ganglion block, well, immediately you're going to have sinus congestion on that side because it's a vasodilator, remember? So we're getting more blood into the sinuses. They're going to be more congested. So let's go to the eyes. So the eyes become more open and clear, less scleral injection. The opposite is true when we do a stellate block. When we do a stellate block, your eye gets a little droopy. You have ptosis, you have droopy eyes, you have bloodshot eyes, you have scleral injection. Your pupil is going to be smaller on one side than the other. C1 hydrodissection doesn't tend to have one side of the pupil be different than the other following the procedure. So we do have some, at least initial changes. Now, the ears often after hydrodissection become more clear and easier to focus, and it also can regulate the pressure in the middle ear. We don't really see that happening with a stellate block. Sometimes you can even feel more congested because there's more blood flow there. Immediately after a stellate block, because there's more blood flow to the inner ear, it's typical that you'll have a little bit of vestibular dysfunction where you want to kind of lean to that whatever side has that block because there's just more blood supply in the inner ear on that side. And definitely sometimes you'll have an increase in coordination and vestibular function immediately following a C1 hydrodissection. So both enhance the ability to focus light. Somebody who needs a stellate block usually has overdilated pupils, and that one of the biggest symptoms they're going to see is they're going to have a hard time dealing with sunlight or bright light. And they're also going to have a hard time driving at night because the glare from the lights at night becomes overwhelming and they can't regulate that. So I think the biggest thing, if you need a stellate block, you're going to have more glare. At night, you're going to have difficulty with the light. If you need a C1 plexus, well, maybe, but that's not as predictable. Certainly, both are going to enhance that pupillary function. When we're looking at irregular heart rhythms, both can affect those irregular heart rhythms. I think slightly more likely if we have a irregular heart rhythm, it's going to be changed with the C1. But I do see that happen with both sides because it's autonomic nervous system dysfunction, and we're addressing the autonomic nervous system in a dramatic way. Okay, so the C1 hydrodissection often improves taste because we're enhancing the function of those nerves. When we do a hydrodissection, the glossopharyngeal, hypoglossal, and vagus nerve. Stellate ganglion block also tends to improve taste and smell, although it's not going to be quite as rapidly. We're enhancing that function. So there are studies that prove that stellate ganglion block improves taste and smell, and they're published studies, and Shawn Mulvaney has done some. Other people have done studies on that. Clearly, it's a thing, and it's effective. We do see that change. If you don't see the change completely, then you may want to think about, hey, we do a hydrodissection of C1. Immediately following a C1 hydrodissection, people often have an improvement in vocal function due to the innervation of the superior laryngeal nerve. So the superior laryngeal nerve it comes off of the vagus nerve, but it's a separate nerve at C1. So we're enhancing that superior laryngeal nerve, and there's another laryngeal nerve that comes off lower, but it comes off of the vagus nerve as well, called the inferior laryngeal nerve, that can also be affected by that C1. So it's not unusual to have an enhancement in vocal function immediately following a C1 hydrodissection, within 5 minutes. Stellate ganglion block, on the other hand, is a local anesthetic, often will leak and block the laryngeal nerve or the vagus nerve, and you lose vocal function on that side. You have a very hoarse voice. Sometimes you get a lump in your throat. Sometimes you have difficulty swallowing the first 6 hours or so after the block. Later, a lot of times the voice will still be enhanced and improved, but it is not quite as predictable. Like if I had a cold or a flu that had me, and I had a patient that had a cold or flu that needed to sing or needed to use their voice, stellate block wouldn't be my choice. I think the C1 would be the direction to go, and maybe hydrodissect the vagus nerve at C5. So we do see those things be effective, and now that we have these tools, I think we have a great way to address these problems with, hey, if you can't talk, you can't swallow, this is a big deal, and these cranial nerve problems are big deals if you're an individual that's suffering. So let's use our new tools. Both may enhance the electrical function of the heart. You think of the stellate ganglion block is probably going to increase your stroke volume because you get a more complete relaxation. It's probably going to be more effective for improving endurance than a C1. C1 does improve heart function as well. It would improve endurance, and definitely if somebody has a postural hypotension, C1 is something that commonly will correct that. Sometimes that is corrected with a stellate ganglion block as well. Not as predictably so. So if somebody came in with postural hypertension, I would want to do a C1 first. If they had a postural hypertension, they got worse after a stellate block, I would want to immediately do a C1, and I would probably improve their regulation of their blood pressure, because you're using different functions here. So the C1 hydrodissection restores cranial nerve function and in vision, hearing, and smell post a concussion or stroke. Stellate ganglion block is probably slightly more important post-stroke, because a lot of times post-concussion or stroke, because we're enhancing the blood flow to the brain. If you have a TBI that's severe and the brain is not functioning very well, it means it's very, very slow. That person has lost the ability to move and talk and think. I think I would start with the C1. We tend to start with the C1 first because it tends to stimulate the brain versus help it relax. If the brain is already too relaxed, maybe a stellate block isn't the first thing we want to do. Okay, so if we go to that sluggish feeling that, just can't think right, can't think clearly, we're looking at a C1 as the first choice. Now, the stellate ganglion block will help with that brain function as well by enhancing blood flow to the brain, and also by taking the stress off the nervous system so the nerves can function more clearly. We're more focused when we're more in the moment. So as we take all the background noise away, we enhance focus, and but that's going to take not immediately, not quite as dramatic immediately following the stellate block as the C1 hydrodissection would be. C1 hydrodissection has been known, there's not studies on this, but we have seen this clinically, can increase, not always, can increase symptoms of schizophrenia, whereas in the same patients, often the stellate ganglion block will decrease the symptoms of schizophrenia. And that may be because schizophrenia is maybe a hyperactive state in the brain and nervous system. We always think of the sympathetic and parasympathetic nervous systems as, a part of the sexual function as point and shoot, point being parasympathetic, shoot being sympathetic. So just with that logic, C1 is more likely to enhance somebody's ability to achieve an orgasm or ejaculation, where a stellate ganglion block is more likely to help somebody's ability to achieve an erection or engorgement. So that parasympathetic side versus the sympathetic side is showing itself. And that said, C1 is going to affect both, and stellate ganglion block is going to re-regulate the system. It's going to affect both. But you kind of want to think, okay, what direction do I want to go here? Which one do I do first? These are obviously, like I said, the big guns, so we can make a dramatic change in those functions. The other thing I want to think about, and I'm just going to add briefly here, it's not part of this discussion, but hydrodissecting the ilioinguinal, iliohypogastric, and pudendal and obturator nerve also have dramatic effects on sexual function. And I don't want them to be discounted. I think we got to start thinking about that, because these are big guns for that problem as well. Okay, so let's go back for stellate ganglion versus C1. If we have tachycardia or bradycardia, C1 is a good choice. If we have tachycardia, stellate ganglion block is often a good choice. If we want to increase stroke volume and efficiency, a stellate ganglion block is probably a better choice. You want to correct electrical problems, probably C1 may be a better choice to start with. That said, both are massive effects on the autonomic system. So both are important, and either one could be the best solution. We just want to think, what do we do first, and where do we give up? Give up means go to some other modality. So we have all these things. They are not the end all by any means, but these are big guns, big changes we can make. C1 hydrodissection may decrease the time before achieving maximum heart rate during exercise. It means your heart rate may get faster, more quickly after C1. Some people need that. Whereas a stellate ganglion block would probably increase the time before achieving maximum heart rate. So your heart rate is going to stay lower longer for endurance activities for most sports. That's a good thing. So both are important. Depends on what your goals are, and we need to be aware of those effects when we're deciding which one to do first. I think we're often going to do both. So stellate ganglion block, we're going to go to a little bit more directly. We talked about the location of a stellate ganglion block between longus coli and longus capitis. The block will often incidentally block the vagus nerve, but a lot of times people will directly block the vagus nerve within the carotid sheath, along with the stellate block to reset the entire autonomic system. I think it has a slightly different effect. And that block is not as well studied, but there is studies that show that it causes a decrease of weight of 22 pounds over extended period of time over years. There are studies that show that vagus nerve has a block, has a dramatic effect on functional MRIs. So there is a use of this vagus block, and I do find that a focus on one or the other when doing the stellate ganglion block has different effects. So for PTSD, sometimes I just would go for the stellate ganglion block. For a stroke, sometimes we'll go for both. So there's all these different factors to play in. I just want to go through the different styles. The one style then is, we do a stellate ganglion block. We block the sympathetic chain at C6 with possibilities of that local anesthetic also blocking other nerves. Our goal is to block the sympathetic chain at C6. The other style is to block at C6 and at C4. And there are studies that show that sometimes this is more effective. And a lot of that is maybe we're using more anesthetic. So that's two. One is just at C6. One is at C6 and C4. And then the third one is we're going to block at between C5 and C6, and we're going to make sure we get a good, clear block of the vagus nerve and the carotid sheath, as well as the sympathetic chain. So that'd be the 3 styles. So intending to block the vagus, not intending to block the vagus and blocking C6, not intending to block the vagus and blocking C6 and C4. Okay, so those are the styles of stellate ganglion block. You're going to read about those. You're going to see those talked about in studies. So those are the types of stellate ganglion block. Now, in the literature, we want to have people do tests. The PCL test. Here you see the PCL-C and the PCL-5 form is mostly used. So the PCL-5 form can be downloaded online. It's government websites. And this is the standard form used now for research on stellate ganglion blocks. Older research was using the PCL-C, so I think I have them both here. And they're very, very, very similar. So when you go to the next standardized test we're going to do, which is now for the NSI to assess symptoms of concussion or a mild TBI. So those are our 2 go-to forms that you want to have people fill out. Now, I think it's relative that you have to say most soldiers who experience PTSD, most soldiers that experience PTSD actually have a concussion along with the trauma. That concussion kind of softens you up and makes you more vulnerable to experience a lasting overstimulation of your nervous system. So that NSI form and the PCL-5, we need to have those in our offices and be testing people using those, and then treat them appropriately. And we need to start thinking about, hopefully we're thinking about, both a C1 hydrodissection, stellate ganglion block, along with the other autonomic manipulations that I know a lot of physicians are using, and not to discount those either, as well as the therapies and psychotherapies and therapeutic modalities that practitioners are using to address these issues. And one thing I wanted to add with these psychotherapies, cognitive therapies, EMDR, all these different things, if you're doing these therapies before somebody has a stellate block or a C1 plexus, it's a lot longer and a lot harder. And I think it's like, you want to program a very dysfunctional brain, or you want to program a more functional brain. So you get a stellate block first, you have a more functional brain, more receptive to learning, more receptive to being in the moment, more receptive to hearing what you have to say, and more receptive to improving. So I think what you're going to find is, rather than be afraid of these modalities taking away from your business or practice, let's have you focus on actually embracing them and then getting better results in everything you do in your practice. You're not going to lose people. You're going to get people better, faster, and you're going to get a better reputation, is what I have been told from multiple practitioners. Okay, so post-recovery from a stellate block, you're going to have ptosis, you're going to have Horner syndrome, you're going to have ptosis, you're going to have anhidrosis, you're going to have meiosis, a smaller pupil, a bloodshot eye, a dry eye. So patients almost initially start blinking a little bit more, and a droopy eye on one side. So that Horner scale is rated for research purposes as well as for clinical purposes on a scale of 0 to 6. That rating scale on a scale of 0 to 6 is a 0, 1, or 2 for how droopy the eye is, a 0, 1, or 2 for how small the pupil is, and a 0, 1, or 2 for how bloodshot the eye is. A 4 or better is a pass. If you don't get a 4 within 5 minutes after the block, we have the patient sit up and get them and evaluate their Horner syndrome. If we don't have a 4 within 5 minutes after the block was not adequate. So we're going to do more. We're going to add more anesthetic, maybe a slightly different location to make sure we got that block. We don't want to come in and have a patient get a procedure and not get the desired effect. So in the past, too many providers have not, assured that they had a good stellate block, and people failed to get better, and they kind of lose a reputation of the procedure. So we want to make sure that we have a valid Horner's response. And that's a request by Shawn Mulvaney to all providers to do this, that actually do that rating system and document that for future research purposes. So the possible post-stellate ganglion blocks effects from diffusion of local anesthetic include hoarseness of a voice, cough, lump in the throat, difficulty taking a deep breath, and that's due to the phrenic nerve being blocked, Lump in the throat is due to the recurrent laryngeal nerve in most cases being blocked. Ear and toothache pain, often due to irritation of the or blocking of the greater auricular nerve. Now, the greater auricular nerve is in the cervical plexus. Then the needle is going to pass through that cervical plexus, sometimes irritating those nerves, and that could cause this kind of jaw pain or headache. Could actually affect the lesser occipital, could give you a headache, or the greater auricular give you jaw pain, and a toothache type pain would be not unusual, just because of that cervical plexus is affected as the needle passes on its way to the target underneath the sternocleidomastoid. The other issue that we do see is, especially with women more than men, the head feels like it wants to fall back because we're blocking. There's enough anesthetic in that longus colli, longus capitis. Longus colli is a big muscle that holds the neck from falling back. It's an anterior flexor of the cervical spine. So when we block that, like I said, women with less muscle than men or very thin necks tend to feel like their head's going to fall back. So that's also a normal temporary side effect from the diffusion of local anesthetic following stellate ganglion block. So the typical symptoms that we want to see is that sinus congestion on the side of the block within 5 to 10 minutes, probably usually within 5 minutes or less of the block. We want to see there's usually a directional sensation of wanting to lean towards the side of the block when you stand up or sit up. We want to see some, we don't have to, but we often see positive emotional changes, feeling more at peace, feeling high or buzzed, or having a clear focus consciousness, being aware of different sounds, being aware of different things they haven't noticed before. A lot of times just enhanced awareness, people reevaluate their life and make changes in their life that are positive for them. There's a typical sensation of, typical for people to feel like their face is like drooping or numb a little bit. That's the effect of that greater auricular nerve again. A temporary effect, fairly normal. And we kind of expect that to happen. I want to go through this the C1 nerve root, kind of the approach. You can see it's really not C1 nerve, it's C1 plexus approach here. So this is a little bit inferior, not interior. So we have this little inferior approach I just slid the probe, a short axis linear slide below the target, so I can see very clearly this internal jugular vein in that plane between between the rectus capitis anterior and the digastric muscle. On a little bit more to the left of that screen, you can see the parotid gland, and more superficially, you see the sternocleidomastoid. So you can see that plexus of nerves is going to sit in that fascial plane, that fascial line from the digastric down to the internal carotid artery. And that's, when we go scan up, we're going to see a different picture. Okay, here we are, just a little bit more, cephalad here, actually. So now we're seeing the transverse process of C1 here, and we see that plexus of nerves kind of wrapping right around. So this is the posterior approach. So that posterior approach, the needle's coming from the back. A lot of times what we're going to do is we're going to evaluate this anatomy here. So we're looking for that. Where is that occipital artery? The occipital artery is in that fascial plane as well. So if the occipital artery here, it looks like it's almost down by the internal jugular vein. And that occipital artery could be in the way as we approach, coming from the this is actually the anterior side. It says posterior. This is actually the anterior approach. Okay, so this is mismatched. So you see, as we come in from the anterior side, there's no vessels in the way, and there's no parotid gland in the way. A lot of times the parotid gland, this white patch here, will be in the way of that approach going to the C1 plexus. So the parotid gland is not in the way, there's no arteries in the way, so we have a anterior approach versus a posterior approach. So the image here, let's see, let's go down to the next one. Okay, here's the image of the anterior approach on the patient, and with a posterior approach on the screen. Okay, so this will be we see on the screen as the needle's coming down from the from the anterior side, and there's no vessels in the way either way. I think in this patient we probably would want to have that anterior approach, but the posterior approach is valid as well. Come right over that C1, so we can hydrodissect this fascial plane all the way down to that artery down there. So here we see again the C1 posterior approach. Now we see the approach for the stellate ganglion block. Here we could see this is now the carotid artery. So we're going to come in from the right of the screen, coming down, and we see there's some radicular arteries here, right at the edge of, right over top of the Chasnax tubercle. So I'm going to go between those two radicular arteries. Now this is flattened down. We have a pushed and flattened aspect of the internal jugular vein. So we want to go between those two arteries, underneath the jugular vein, to that fascial plane between the longus capitis, which is more superficial, and the longus colli, which is larger at C1. And we'll do that hydrodissect, that block where we kind of hydrodissect and block that sympathetic chain right here. We're going to go to the vagus nerve block. So we see the vagus nerve block. Here we're coming in, and we're coming from the posterior side, posterior and lateral, and we're coming in, towards the, underneath the internal jugular vein to approach that carotid sheath, this little triangle right to the lateral side of the carotid artery. And we're going to deposit our local anesthetic there, as well as at the sympathetic chain, and we're going to do that vagus nerve block. And that's one of the styles of the stellate ganglion block. So remember, we had C1 and C6 and C4, and then where we're blocking at C6 and C4, the sympathetic chain. We also have where we're blocking at C6 only, and we also have where we're blocking the vagus nerve and the sympathetic chain between C5 and C6. Here's a vasculature at the C1 plexus. You can see here, this is right around, this is in the spinal canal, vertebral arteries around the spinal cord, the deeper artery underneath the digastric here in this fascial plane between digastric and rectus capitis anterior is going to be the occipital artery, and the deeper to that is going to be the internal jugular vein. You could even see the internal carotid artery here sometimes. So that's that vasculature at the C1 plexus. And here we can see that occipital artery here between the rectus capitis anterior and the digastric. It's going to pass out. It's going to wrap over or under the longus capitis, and continue on up to the occipital area. You can see the other muscles here too that we're going to kind of look at as frameworks: the inferior oblique capitis, longus capitis, semispinalis capitis, sternocleidomastoid, and the digastric. So that's kind of the musculature around that C1 plexus with the parotid gland anterior. A lot of times, the more inflammation somebody has, the bigger their parotid gland is. So we see that, we note that, and we tend to avoid going to the parotid gland if we can. One of the reasons is that the parotid gland can get irritated and become inflamed. The other issue is that there is quite a few nerves in the parotid gland. You're going to have the greater auricular nerve, the facial nerve, and the trigeminal nerve. So you have some quite a bit of innervation, quite a bit of sensitivity there that we'd like to avoid if we can. Here you can see the occipital artery coming under the longus capitis. We just short axis linear slide. We slid the probe closer to the occiput. And we see that artery coming out, defining very clearly where the longus capitis is. Either goes over or under it. And we just need to be scanning up and down and know where those arteries are, know where they go before we do a procedure. One more time, we're going to just kind of review this. This is the Chasnax tubercle. We have the CT here. We have the sympathetic chain, SC, the vagus nerve here in this triangle next to the carotid artery, and then we have the internal jugular vein right over top of that. Here we have the longus capitis, the longus colli, little triangular muscle here, very small at that level. Here we have the thyroid gland, larynx, sternocleidomastoid, and the C6 nerve root, along with the C6 vertebral body right here. So a little more anatomy here. We see the C6 vertebral body, see the nerve root. In this image, we do see a little bit of the omohyoid underneath the SCM. So that's just, we want to be aware of this anatomy. We want to know where the vagus nerve, the sympathetic chain is. Now, because we're slitted off of the tubercle here now, we're a little bit below or above the Chasnaex tubercle, and we can see the vertebral vein and the vertebral artery. And now if we were at C7, which just looks like that's where we're at here, the stellate ganglion is actually there at C7. This is a bigger ganglion. And it's sitting right on the vertebral vein. The reason we don't go to C7 is if you go too far, then you're going to inject high concentration of local anesthetic into the vertebral vein, which would not be a good situation for anybody. Okay. I want to go over a case of just an example of what can happen with C1. This C1 case, you can see this. This is somebody that we saw in Los Alamitos, California. 73-year-old Caucasian female presented to the office with a heart rate in the 40s and 30s. Blood pressure was low as well historically, but heart rate was normally in the 70s and blood pressure normally in the 120s over 70s. After COVID vaccine, her heart rate would episodically decrease and she would get near syncope or even syncope, or she would pass out or feel like she's going to pass out, especially when she stood up. She was scheduled to get a pacemaker the following week. In the office, she had a heart rate of 34 beats per minute, blood pressure of 90 over 60. C1 hydrodissection was performed, and bilaterally, and her heart rate increased to 72 beats per minute within 10 minutes. It sustained itself for about a week, and then the bradycardia started to return. The hypertension started to return. We recognized that this was an inflammatory process, so we used a more advanced regenerative solution to do the same C1 hydrodissection, and her heart rate increased to 72, and her blood pressure stabilized, and she has been held a healthy heart rate and blood pressure for the last 3 years following that procedure. So just an example of how big of a deal this C1 plexus hydrodissection can be for treating this postural hypertension or bradycardia. Just as effective for that tachycardia often. I want to go over a little bit about the master of the stellate block. Dr. Shawn Mulvaney, Colonel Shawn Mulvaney, Special Operator Shawn Mulvaney. He's done a lot of studies here. Left-sided stellate block compared to right-sided stellate block, which is something that we had come up with. So when we do a stellate block, the initial studies were all on the right. There's just more sympathetic. It's just larger sympathetic neurology on the right. We did find that there is people don't respond to the right sometimes, and they respond to the left. So there's a study done, and we had found that to be true. Proved that there's one of the biggest studies done was in JAMA, a large case-controlled double-blind study showing that stellate ganglion block was worth consideration, and that was kind of what spurred the 60 Minutes episode on stellate ganglion block with Dr. Mulvaney, as well as a lot of the meetings with Congress, and two-level stellate blocks we talked about. Also did a study on that. So there's over 30 studies on stellate blocks here. Large case studies showing the benefit of stellate ganglion block for PTSD. I was in military medicine. Another military medicine study where it showed that PTSD symptoms were improved with stellate ganglion block. Another military medicine showing that PTSD can improve global neurocognitive function. And that's what we talked about the military medicine as well. So we have increased function and reflexes and cognitive function as well. And then there's a comprehensive published treatment guidelines for stellate ganglion block with Dr. Mulvaney. And first case study published showing long-term benefits of stellate ganglion block. That was in 2010. And more studies supporting Dr. Mulvaney and Lynch and Dr. Lynch, his business partner and publishing partner, can be found at in Brain and Behavior. Stellate Ganglion Block treats post-traumatic stress, an example of precision mental health treatment. So he goes on with Stellate Ganglion Block. You can see here's a picture of Dr. Mulvaney with my wife and myself and in her office, where we commonly treat people. When on that day we were training the VA, local VA in Long Beach, the first VA to start doing Stellate Ganglion Blocks. Okay, we're going to go over, the secondary treatments. I say secondary, not lightly. These are important treatments that a lot of people benefit from, but they maybe are not the biggest guns, as big of a gun as changing the autonomic system as a C1 Plexus Hydrodissection or Stellate Ganglion Block. Certainly not as lasting and predictable, but vital. So vagus nerve stimulation, there's a lot of people that have been focused on that, and there's some great technology there. Meditation, obviously, it's been around for a while. Great technology. Breathing exercises. I think we need to really, focus, heavily on those as well. Acupuncture, I think of it. Acupuncture is really modulating it's a fine tuning of your autonomic system, at least my understanding of it. It's a fantastic technology, and may be underused as well. Chiropractic manipulation, also a direct fine tuning of your autonomic system, kind of by segment. Vital, obviously, is very, very big part of healthcare for a lot of people. Weight training. Now, weight training, we can't discount weight training. I think that's one of the big things, because a lot of these other things, you have to go this. You take the patient out of it with acupuncture and chiropractic. The vagus nerve is maybe something you have to add, but weight training, I think, is underused. So weight training is direct exercise of your peripheral nervous system, of your autonomic nervous system. You're basically vasodilating some parts of your body and vasoconstricting some parts of your body, getting that pump. So I think that's vital to balancing your system, as long as you get your whole body working. You can almost look at somebody and say, what muscles associated to that organ. That muscle's weak, that organ's weak, this is where the person's weak. A nice balanced muscle, ability to get an adequate increased blood flow, adequate pump to each muscle, I think is a way to maintain your autonomic function. And really, the connection of that those muscles to your brain and to your body is probably highly important for healing and recovery from trauma of any nature. So I don't want to discount that. I also don't want to discount sprinting. And I think that's another thing that's underused, is sprinting. Most people don't sprint after they're like 30 years old. But sprinting or a high intensity, rapid intensity exercise. And it's not really weight training, but that explosive rapid intensity exercise. Now we're going to get not just the peripheral vessels, we're getting now our central vessels, which a lot of times are our most important vessels, are our cardiac vessels, our aorta, our vena cava. All of these vital central vessels are going to be treated and really are forced to vasodilate when we sprint. So that rapid, high intensity exercise, I think, cannot be considered or undermined in a way to manipulate the autonomic system. Now, the other thing is, when you have people that have this overstimulation of their nervous system, that explosive, massive stimulation of your nervous system with a sprint can be very helpful as well. Kind of more similar to that relaxation or that peacefulness that you get after, a stellate block. Of course, like, it's not as lasting, but a consistent use of that technology can make a difference. And I hope that we see more people use that as well as a treatment modality. Problem is, somebody has to be healthy enough to do it, and that takes some work. Biofeedback. Now, it's just, these brain scans, these electroencephalograms, testing as well. Very, very helpful, and a little bit more fine tuning, but very, very helpful. And ketamine therapy, also one of the common things I used in a lot of the offices that we work with. Maybe that the third tier, most doctors that do all three of those procedures will think, hey, the biggest effects are the stellate and the C1, and the ketamine falls below that. And the psilocybin and the psychotropics follow somewhere in there as well. I think ketamine is probably psychotropic, but we want to consider all of those therapies and not devalue any of them. But we also need to say, hey, C1, hydrodissection, stellate ganglion block, are we as clinicians, are we as a society using those appropriately? I think that we have to almost think, you have a divorce, I can have a stellate block. Graduate school, graduate college, stellate block. Get through residency, stellate block. During residency, stellate block. There's all these kind of periods of life. Your spouse dies, first breakup, taking care of a sick parent, traumatic accidents, assaults, major surgeries. Most want to think, why don't we do these stellate blocks, on a regular basis at these certain parts of people's lives, these certain important events that a lot of times are not well recovered from. Let's add the appropriate therapy at the right time, so we don't have long-term mental health issues, long-term functional issues for our patients and our society. All right, so I just really want to put out a big thanks to everybody who's taking the time to listen to this podcast. I think it's a vital podcast, a vital way to change lives for so many people. You have resources, my website. You can reach me and see me at YouTube. I have a YouTube channel, Dr. Shawn Tierney DC RMSK at YouTube. You can subscribe to that channel. You can look at all the resources. I also have a website, StellateGanglionBlocks.com. That's more of an educational website than it is. I don't think of it as an advertising website. It has videos of people's response, their experiences afterwards, which I think is vital for somebody that needs that. Hey, watch the video, see what somebody's went through, see their stories. It'll take about an hour or two to watch all the videos. You're going to cry if you watch them. You're going to break down. It's going to be an emotional event. But you can see that these things are changing people's lives, and we're in the business of changing people's lives for the better, right? So my hope is that this little talk is another step towards helping you as a person, you as a provider, us as a society at getting stronger, better, healthier, more vibrant. Thank you again.